All right, welcome. I think we're going to get started with the live surgery. Tony, can you hear us?
We can hear you fine. Nick?
Good morning.
Good morning. Can you hear us okay?
We've got you. Great.
Great. Okay, I'm going to go ahead and get started if that's okay with you.
Perfect.
All right. First of all, I'd like to say welcome to everyone to the first annual Chicago Sports Medicine Symposium. This has been really a great honor to be able to put this together with Nick, and we have some tremendous faculty that will be speaking to you over the next 3 days about everything related to sports medicine. We hope that you will get a chance to meet the faculty and interact with them, ask your questions, and come away with this course with a lot of take-home messages that you can use in your practices, whether you're a physician, a physical therapist, or any type of professional that deals with sports medicine. So again, welcome and thank you so much for your support. To start out this course, we're going to do a live surgery. And the gentleman that we have this morning is a young man. He's a 15-year-old young man who's a swimmer, a very avid swimmer, and hopes to one day be a collegiate swimmer. He has had more than a year of problems with his shoulder that have not been alleviated despite appropriate conservative management, which included anti-inflammatory medications, activities out of the pool, a cortisone shot, and at least 2 months of physical therapy, and then a gradual return back to swimming, and he could not swim. He tried the same thing again, and now a year later, he and his parents come in and say he really wants to swim, but he can't because his shoulder hurts, and it's always in the posterior aspect of his shoulder, and it's not been able to be resolved with appropriate conservative management. So we do our examination of his shoulder, and most of the signs point to a posterior or possibly a superior labral problem, not unusual in swimmers who have shoulder pain that is not alleviated with conservative management. Remember that about 75% of all swimmers will have shoulder pain during their high school careers, and most of it's treated conservatively, so that's what we hope. It did not work here. And so we went to plain x-rays. The regular x-rays were normal, and therefore we proceeded with the magnetic resonance scan. Can we show that MRI study? So what the MRI shows on the couple of views that we have available for you is we have a coronal view as well as an axillary view. And the coronal view, we just picked some selected views. Obviously, there's more than 150 images in a standard shoulder MRI, and we just selected a couple of them. The one on the left shows us his rotator cuff is intact. It shows us that his superior labrum does not seem to have fluid that's leaking underneath the labrum. In a young 15-year-old, you may see a little bit of fluid. They can have a meniscal type attachment, but we see none whatsoever. The anterior capsule looks normal. There's no bony abnormalities. When we look on the right view, we see an axillary view, and what we see on this is that there's some signal change anteriorly, which is typical. We see a cord-like middle glenohumeral ligament at the front of the shoulder, but when you look directly at the labrum and on the edge, there's no cleft. It may be difficult to see from your view, I'm looking at it from here, but there's a small cleft on the posterior labrum, and we see it even more when we go further down the shoulder, and this was interpreted by the radiologist as being a posterior labral tear, which is what we expected from his clinical examination. And therefore, having failed a year of conservative treatment, we're now in the operating room trying to help him so we can get back to his sports. So let's go to the patient himself. What we do to do this operation is that we put the patients in a lateral position, and I'll show you why in just a minute. But this is called the lateral decubitus position, as you know, and we pad the head, the shoulders, and the hips to make sure that that's nice and comfortable for him. And in this position, it's very important, especially when working posterior, that you put the patient in a direct perpendicular to the floor and then lean them back about 30 degrees because that puts the glenoid parallel to the floor. It's very important to have this backward lean. If you have it forward leaned, what it does is put tension in the posterior capsule. You have a very difficult time getting in the posterior aspect of the shoulder. And then while we're here in the operating room, we have another chance to examine his shoulder, and we can check for anterior instability. He has the usual laxity that we see in a 15-year-old, which is probably up to a centimeter of motion. And then we go posterior, and what we try to do is see if it'll slide out. Now, what you can't see is what I can feel, and every time I move to this direction, there's a little click. And that's the posterior labrum. It's harder to tell if there's a superior labral pathology, but we can tell there's a little click here, but anteriorly, He's got laxity, but no falling off the front of the edge there. So far, everything is lining up well. You can see on the outside our anatomic landmarks. We like to mark out the acromion and the spine of the scapula, the clavicle, and then the coracoacromial ligament for this left shoulder that we're going to be operating on. Our workhorse portal for visualization is going to be a posterior superior portal in all of our instability cases. That's our starting point, and then we go from there. There's another opportunity for us to examine the shoulder right now before we even put his arm into suspension. So what we'll do is we'll take the arm and put it in a little bit of traction, which mimics the suspension. I've already made the portal previously, and it's coming right off the edge of the acromion. And what I'll do is I'll go down and I'll bump his humerus and then go right into the glenohumeral joint. I can feel the humerus laterally, the glenoid medially, and then we're into the glenohumeral joint. And then while your assistant is holding onto the arm to make sure that you're not scraping the cartilage, we'll insert our scope and we can see inside the shoulder. You can see that, in fact, we're within the glenohumeral joint, so we can turn our fluid on. And we'll get that to work well for us. Our pump was turned off, so we'll turn that back on again. And here's our initial view that we know we're in the shoulder. So looking forward, that's the anterior aspect of the shoulder. We do this especially in our baseball players, but in really any young overhead athlete, it's quite useful information. So while we're looking into the shoulder, and I personally am putting traction on the arm, I can look at the superior labrum to see if there's anything pathologic in this area. I can take the arm and go up into a elevated position, as you see here, and we can see the interaction between the rotator cuff and the labrum that you see there. So in our baseball players and other overhead athletes, when we're looking for this problem called internal impingement, which we'll learn more about tomorrow, we're really interested in the interaction between that rotator cuff that you see to your right, the supraspinatus, infraspinatus junction, and the labrum that you see to the left. And as we go up into abduction, external rotation, you can see how those two structures come in contact. That's normal that they come in contact. What's abnormal is when that starts to separate from the cartilage or fraying on the undersurface of the rotator cuff. So his superior labrum looks good. We weren't worried about that based on his exam and MRI, but something to look at. Now, if I keep traction on the arm, I usually can slide down the back of the shoulder, and we're looking at the rim, and we come to this area right here. It's very subtle, but below the 3 o'clock position, it is not normal to have the labrum separate from the articular cartilage. So it's very subtle, but it's enough to cause him problems, and he has a labral tear in the posterior inferior corner of his shoulder. His capsule looks okay. That's the posterior band of his inferior glenohumeral ligament. We can look underneath the humerus and see if there's anything going on over there, but that's good. And then I'll slide back around to the front of the shoulder. We can put a little traction on the arm and oftentimes see the anterior labrum with just a little traction and make sure everything's okay there. A little change at the 3 o'clock position is not that unusual, but down at the bottom you see his labrum is normally attached until you get right to this position right here. We can also look very carefully at the rotator cuff. So as we come around and look at the top, again, traction on the arm to protect the cartilage, and we can just take a little fluid and the bubbles out, and I can see his supraspinatus back out, his infraspinatus. There's no evidence of a Hill-Sachs lesion. There's a little area where there's no cartilage, the bare area of the humerus, which is normal. If there was a Hill-Sachs lesion, we'd think his shoulder would slip out the front. But we can do a very nice examination of all the important structures and have a good understanding. His superior labrum's okay, anterior labrum's okay, but here's where his problem's at, and it goes along with our clinical exam, his history, and our MRI. So now we're going to take a short break from the scope. Well, hold on to the arm for me. I'll take the scope out, and I'll have the arm placed into suspension. So this is the way we try to evaluate our patients. First of all, most importantly, we got to take a good history. That sometimes is the least amount of time spent with the patient, and it's oftentimes the most important. You really try to find out what the mechanism of injury is. Number two, you've got to do a good clinical exam. That requires that you see the shoulder. In a male, you can have them take their shirt off. In a woman, you've got to get the shoulder exposed so that you can see exactly what's going on, look for atrophy and other deformity. We get good radiographs. We even get some special views to look at the glenohumeral joint. One of those is called a Bergenet view, which is very helpful to look for bone injuries. We get an MRI to look at all the soft tissues, the labrum, the rotator cuff, and then we put that whole picture together and come up with our diagnosis. Once we have our diagnosis, the first thing is, what's the conservative management program that we do for that individual? And then if we can't succeed in getting rid of their problem conservatively, then we have surgical options. You're going to hear about all of this today. You're going to hear about anterior instability with just a soft tissue injury. You're going to hear about anterior instability with a bone injury. You're going to hear about what happens when anterior surgery fails and the patients aren't getting better, what the options are that we have available. You're going to hear about posterior instability, multidirectional instability, and you have to keep all of these in mind as you're treating the patients. We're also going to try to spend a little time talking about the rehabilitation, which is critical, both in terms of the non-operative management, but also in terms of the surgical management. And so we'll go over those things and we'll try to answer your questions on that. So again, as we get started here with our surgical repair, I want to thank you for coming. We have a great lineup for the next 3 days. Instability this morning, rotator cuff this afternoon, and I hope this will be really valuable for all of you. So let's go ahead and take care of this young man's shoulder.
Just for the audience, we do have mics available for questions, so if there are questions that come up during the procedure, please feel free to ask.
So we use that same portal that we had before, no difference, and that's that posterior superior portal, and we'll look in and we'll get everything all set up. I'm sorry, what'd you say, Nick? Sure. I don't use traction. I use suspension of the arm. So what we have here is the arm is suspended with a sleeve that holds the arm at about 30 degrees of abduction with longitudinal traction of 10 to 15 pounds, depending on the size of the individual. And then oftentimes it's quite helpful to have a secondary lateral traction that you see here, so that we have, or lateral suspension that you see here that supports the arm. I also have a towel underneath the axilla, which helps to separate the humerus from the glenoid. So before I was using my arm to pull on this, but now I can slide around pretty easily without any use because we have that very nice suspension of the arm. So this is really the reason why we do this in the lateral position. You can see everything 360 degrees, and we'll have full access to the shoulder and all the places that we need to be. So we do our standard exam again. We don't have to go through that because we saw everything very nicely. And then we'll establish an anterior portal. So I'll take a Wissenger rod. We already did this, so we should be able to just move quickly to the portal site. I try to, when we separate this out sometimes, we'll try to find the exact same capsular hole that we made before. We'll take our dilation cannulas that you can see on the outside of the shoulder, and this helps to dilate up the shoulder. There's one that's about 6 millimeters, another one about 8 millimeters, and then we'll load our cannula on top of that 8 millimeter dilating cannula. So you see this loaded up here, and this slides right over the top and into the shoulder. So hold the camera for me, thank you. And we'll just direct that right in place and keep an eye on what we're doing. So again, we minimize any scraping or irritation of the cartilage. And we want to get one of those threads inside the capsule, which will help hold that in place throughout the entire surgical procedure. And so that works out pretty well. Now, we'll take a probe and we'll examine again, just check a couple of areas. We always want to make sure we understand this well. So again, the superior labral pathology, we will see in some of these young kids that there'll be a separation of the capsule and the articular cartilage, the labrum and the articular cartilage right here. There's not in this young man, so that's totally normal. But you can have a little bit of a lift off here. The cartilage will go all the way up to the attachment point, and that's normal too. You can have a meniscoid type attachment in our young kids. And as we get older, this starts to fissure and crack in our 30s and 40s. So a separation here as we get older is also a normal part of the aging process. Anterior, there's 3 o'clock position. Everything below here should be attached firmly onto the rim. We see the middle glenohumeral ligament, the superior glenohumeral ligament is behind me, and you see the subscapularis in the background. And then way down at the bottom, you'll see the anterior band of the inferior glenohumeral ligament, and we'll come around posterior, and there's the posterior band of the inferior glenohumeral ligament. As we slide across the glenohumeral joint just to check out this area, it doesn't look that dramatic. I mean, it's pretty well here and pretty well here, but we can slide right into this hole, and you can see that this is not normal. So now that we have confirmed our diagnosis, we'll start to prepare this. I'll take the elevator, and a lot of times for these posterior, inferior areas, it's kind of tricky to get to. So sometimes what we will do is come through the anterior cannula, slide across the glenohumeral joint with a sharp angled elevator, and we actually get a pretty good angle to come right over the top here and down into this area. And then we can just slide right over the top to prepare this. It doesn't always work. You may not have the arm position just correct, but it's worth a shot because sometimes this will be the best angle that you'll have to prepare this labral tissue. As you can see, we're kind of working on top of ourselves because we're posterior and we have a posterior labral tear. So ideally, at some point, we're going to move to the front and look to the back, and that's going to give us a lot more freedom. So once we have that elevated up, we'll take a shaver to try to get rid of a little more of that soft tissue. And we'll slide that into place. This one may or may not have a good angle for us, but again, it's sometimes quite tricky from the backside to get this. So that looks like we might scrape up his cartilage a little more than I'd like to, so we're going to hold off on that. So what I'm going to do now is I'm going to switch and look from the front. So we'll turn off our flow, we'll take our Wissenger rod, our switching stick, it's just a metal rod that goes into the cannula, and then we'll slide this around to the front side into the anterior cannula that we already created. So we know we're in the right spot. We don't have to take the anterior cannula out. It's an 8.25 millimeter cannula, so there's plenty of room to slide in and work around. And we'll get our bearings again. So this may look a little confusing to some of you because this is upside down and backwards a little bit, but here we are with, just if we can just leave that on. So if we're upside down and backwards here, if we look at this here, and what we'll see is that we can see that area of the labrum that we saw before, and we can see that very nicely in this angle here. Okay, so this is the anterior cannula. Now, some people try to do this with a single cannula posterior, and that might be possible. Let's have a clear colored cannula with no orange. So we'll slide a cannula over our Wissenger rod and establish this portal as a working portal. I put in a smaller cannula, so this doesn't have all the flexibility as an 8.25 cannula, but we'll just see what we have. So let's take our less angled elevator for a second, please. And we'll see how that works in this posterior aspect of the shoulder. And we can come on down here and kind of peel, and this will help us a little bit. And again, you can see the injury is only from about right here where it's well attached to about right there. So it's pretty small. That's probably why he was able to swim. It just hurt. And he might have been able to do okay for a while, but that's what we have. So we'll take a shaver now, please. And we'll go right into this gap here and see if we can free this up a little bit and establish this a little bit better. So Nick, what do you normally do to prepare your labral tissue?
I do it pretty much the way that you've shown. I often try to elevate it from the front using that mid-glenoid portal just above the subscapularis.
Yep.
I think more often than not the angle's proper, but as you showed us, we can end up scuffing a little bit more of the cartilage if we're too not oblique enough. And then I prepare it from the back as you do. I use a bone cutting shaver or oftentimes a rasp. It seems like that's what you're doing as well, just to help create a little bit of bleeding there. Is there anything you do to the capsule to try to elicit some biologic response?
Yeah, I'm going to do that in just a second. So let's have our slap burr, please, and we'll go ahead and load that up and see if we can get that in there a little bit just to establish it. So with the slap burr, what we do is we're going to need the red rasp in just a minute so we can show what Dr. Verma's talking about. This slap burr has a little hood on it, which will help protect us here, and this will give us just a little bit of what we need to get this prepared here, as he mentioned. We just really want to get, especially in a young man like this, we want to just get a little bit of the bone exposed, and usually that's enough to get these things to heal pretty nicely. So that'll work out pretty well. Now, again, we may be able to do a lot of this through this camera. Let's have the shaver back then for a second. We'll just kind of clean that all up. We can have the 4.0 shaver. Go ahead and take this. But you can see that some of our angles are not perfect with this, so we're going to have to figure out how we're going to get down low to be able to bring that capsule and tissue back up in a good position. And what I find in most of my cases of instability is having two cannulas on the same side of the repair is really very valuable. So what we're going to do is we're going to create a 7 o'clock portal here and get this all freed up and ready to go. So we'll hold our cannula in place there. And let's have an 18 gauge needle. Just want to show you from the outside. Well, let's just have a Wissenger rod because we already examined that. So we usually come about 3 centimeters down from the corner of the acromion into this area here. And we'll go straight in there. And you can see where we're coming in the capsule. But the nice thing about this, and we'll hopefully find the exact same point before, as you see the access we have, there's the 6 o'clock position to the shoulder. There's about the 5, 4:30, and 4 to 3 o'clock position here. But we have great access to the shoulder, and we can get our anchors and our fixation devices in a really good position. So this works out well for me to have the 7 o'clock portal and have a secondary portal for fixation, as you see here. We'll go ahead and put this in place. Just hold the camera for me.
I think it's important, Tony, that you get the obliquity that you're showing here. I think as you put your guides in for the anchor insertion, you'll see how easy it can be to skive the articular cartilage. So as Tony's putting these implants in place, you'll see how his hand becomes almost perpendicular to the glenoid when we're looking from the outside shot.
Absolutely. So now that we've done this, let's have our red rasp, please. So as Dr. Verma mentioned, people have talked about, let's have the opposite direction. People have talked about exciting the synovial sites. You take a rasp and you just kind of scrape this tissue. And really what it's doing is that there's little tiny blood vessels in this capsule, and there's some cells on the outside. And by scraping this and irritating this a little bit, it kind of doesn't look as pretty as it did before. But what it does is it creates a healing response to the capsule and allows the capsule to stick to itself as we go further up the shoulder and secure that into position. So we can take all that and secure that nicely and make that work pretty well, as you see here. So just a little bit is, I think, all you need. And then what we're going to do is, there's a couple of different options in terms of fixation. There's a variety of different anchors that you're going to hear about today. And there's a variety of different ways. You can do this with sutures, which is the classic technique, or you can do this without sutures, with tapes, or with sutures without knots. So what I like to do in many of my patients is I like to fix that inferior corner with a suture anchor that has sutures, and I do this in a knotted fashion, but lots of people have converted over to a knotless fixation, and we'll show you that too. But we'll start out with an anchor that's 3.0 millimeters in its overall size. And we could actually even go smaller to the 2.4 if we have that available. And this young man, we might conserve a little bone with that. So I'm going to change up my surgical team here. And I didn't give him a warning about that. I apologize. But are there any questions about our exposure or our approach from the audience, Nick, that I can answer?
Questions? I think it's been pretty clear, Tony.
Okay. So there, again, as I was mentioned, there's a variety of fixation devices. I must admit, as we all have our favorites, it's oftentimes quite hard to tell from the literature that one is better than the other. Most of the studies are done in a lab, and it's biomechanical studies, but there's rarely, if any, studies that are done in the actual clinical outcomes of using one anchor versus another anchor in a similar patient population, suggesting that one is better than the other. So that gets a little confusing to all of us, but I think that most of us will use what we learn from basic science studies, some animal studies, and then our own preferences in terms of the tools that we have available along with our anchors to do the fixation. So again, you'll hear a lot of different options today. So hold on to the scope for me, and we'll hold this in place. And then we've got that right up and onto the rim. We'll take our drill. This is one of the smaller anchors, and it's important to be able to be pretty much straight on. As Dr. Verma said, we're almost straight up and down when we put this in, as you can see from the outside. Now, if you have one of these smaller anchors and you have to lean into the humerus a little bit, which we do sometimes for instability, there's a tendency for these anchors to kind of get bent, or the inserting device to get bent. So you have to really be on the line that you need to be to make this work. These anchors are amazingly strong for how small they are, which is great. And we put that down until our laser mark tells us that we're all the way in, and we pull on that to make sure that it's okay. And then what I'll do is I'll take a suture retrieving device, and I will separate this out. Now, there's a lot of different ways, again, to do the suture passing. And what I have a tendency to do is, if you can hold the camera for me, maybe it would be best if you came up here so that you can do that for me. So hold this here. Thank you. Are you okay with your visualization? Okay, great. So I'm going to pass my suture passing device through this cannula, and I'm going to grab these sutures. So what I'm going to go ahead and just take all of them out and put them through my accessory portal. You can do them one at a time if you like, but I'll show you how to do this when you have more than one suture in your cannula. And then we're going to take a suture passing device that has a curve to it. You can use one that is a straight line, like it's called a crescent, or you can use one that's curved to the right or left. This is curved. The reason why I like this is because it gives me that bias to reach down and pull up. So you see the posterior band in my inferior glenohumeral ligament, and I'm able to fix that. I think one of the main causes of failure of posterior instability, or any instability, is failure to resolve the inferior component. Now in this young man, we can see his labrum's pretty good inferiorly, so I don't think we need to do a big shift, but I still think it's important that we incorporate in not only bringing it back onto the rim, but also giving it a little bit of a shift upwards. We'll poke through the capsule. You just do a poke like that, and then we back up a little bit because we don't want to be digging where the axillary nerve is. The axillary nerve is actually further lateral than this, but we're right underneath the capsule safely. We lift up on the capsule, and then we aim towards where our sutures are. We just kind of gradually find the cleft, if we can, between the labrum and the articular cartilage. And so we'll just work on that for a second to try to get that as accurate as possible. And that comes out there, and then we'll have a suture retriever. And if you have multiple sutures in one cannula, if you try to pull this out and then tie it around, and you're going to get this complicated. So hang on to those for me. And what I'll do is I'll select one of them. So I'll select one of the blue or blue-green ones here. And then I will grab the suture passing device at the same time. And then as we pull them out together, we'll keep them separated, and then we'll put a loop on that suture that we're using, the PDS suture. There are other devices that have a wire loop that can capture. Those work very well too, so that's perfectly fine. But then we'll capture that. We'll tie a nice secure half knot on this, and then we just back this out the same way we put it in. And that will grab that suture, and because we grab the two of them together, it doesn't tangle. And so we'll come on out. Hang on a second. Just have to pull this guy out. And this will come over the top like that. And so we're in good shape here. Now it does look like it there, so we just have to keep moving it. And now you've got it in a nice, good position. Now what I'm also going to do is we're going to put our first stitch in as a mattress stitch. So to move this up a little bit and secure that inferior component, we're going to actually grab a little bit further posterior inferior. And we're going to separate the two a little, and then we'll come back to where our sutures are at again, sliding over the bone of the glenoid. This one's sometimes a little tricky to get it in the right spot, but we'll try to get it close and try to get through that labral tissue right on the edge. And once we come through, we can then tie our knot, and that'll roll everything up and make a nice little bumper for us and secure that into position. So almost through here. There we go. And so I'm going to grab the other blue suture.
Tony, if you had a laxity issue here without the labral pathology, would you use an anchor or would you just use the labrum?
So early on, we thought we could just get away with using a sutures, and it looks like the fixation is good enough to do that in many cases. But what we recognize, and I think Jim Bradley has the best paper on it with posterior instability, that the few failures that he had in that situation, he did not use any anchors. And in those individuals that he used anchors, he did not have any failures. So I think the principle is that although we like the labrum and it looks nice and maybe a fixable tissue, it oftentimes is not as secure as we'd like it to be. So I like to put an anchor at the position of the most amount of instability. So one or two anchors in this position is very helpful for us, I think. We'll take a knot pusher now and we'll tie this down. And so I'm just going to use just a simple knot pushing. I don't do any kind of fancy knot. It's just multiple half hitches. And we'll go across this way. We'll pass point. We'll bring that all the way up. As you see there, we start to get that bumper effect. And we're going to really finalize that once we put our another stitch in there, because what we're going to do with our second stitch is we're just going to put a simple pass on that, and that'll roll that all up on the edge and make that look very nice. So typically our knot passing is we have to do up to 5 passes. So we put 2 in one direction, and then we put the other one over the top. Then we change posts, and then we put another knot over the top of this. And this makes it so the knot is so secure that before it slips, the suture will break. And when we're using this super strong suture, that's really powerful to hold things in place and make sure that the reason why these things would fail is not because the suture, but for other reasons. Usually the tissue comes apart. We have a special suture cutting tool that we just slide down over the top. It usually rides right down on a rail, and then it has a little 3mm stop, so we have that cut there. So now we'll take our suture passing device again, and we're going to go around this, and we're going to essentially, some people talk about a Mason Allen-like arthroscopic suture suturing to do this. So I slipped out a little bit, as you see. Sometimes we can work through there just fine, but we'll kind of come through here. I know that my first stitch was a good spot to come out close to my anchor, so we'll come around here and then come up through our tissue again, as we did with the first one, and we'll put that all around there. So we'll put a suture retriever now.
Tony, just for clarification, you're using an 8mm cannula at the 7 o'clock position, which is the suture working portal, and you've got a 5 up top?
I do.
Okay.
Wait a second. Okay, so my assistant, what he did is he let the sutures go, and then he grabbed the suture, and now he doesn't know for sure if it's the one that I pulled through or not. So we have to do this all in one maneuver. So what we do is we grab the suture and the suture passing device at the exact same time. Let's come to the outside of the shoulder. And as we come to the outside of the shoulder, we've got to keep the two separated so they don't get mixed up, or you're going to tangle your suture. So it's very important to be meticulous like that when you're using multiple sutures through the same cannula. You can't just kind of keep throwing things through. You'll tangle this all up, and it'll look like a fishing line that your kids got caught on a tree stump, and it'd be impossible to get untangled. So we're trying to follow those steps every single time the exact same way. So go ahead and hold the scope for me. And then what we'll do is take the suture retriever again, and then we'll grab that other suture, and then we'll tie our knot. So knot pusher, please. So I know exactly which one is my post side. That's my tissue side. I can check that again just to make sure, and come straight on down here so we know that that's the one I want to be on. It's not tangled, and then we're in good shape. Now, I think that we're in a good angle so that we can go ahead and move on to a knotless anchor fixation with our next one. So I can let my surgical tech know that we're ready to go. Our next step will be a knotless anchor, so we can show you that technique to secure this down into place too. And so while we're finishing tying our knot, they can get that all set up for us. There's a different drill typically. There's a different targeting device in some companies, so you have to just be aware of the tools that are available and make sure that that's all working good for you. Nick, what do you like doing down here? Do you do all knotless anchors, or do you like to put some sutures, or what's your preference?
I use all standard suture anchors with knots. I use generally double-loaded all suture constructs down below. I think that they're nice and small but strong, so I can get multiple points of fixations. I definitely use double-loaded anchors in generally 2 simple suture configurations in the primary direction of instability, so either anterior, inferior, or posterior, inferior, and then I just continue with single-loaded anchors as I move up top. But as Tony pointed out, there's multiple ways to skin a cat. We have some reasonable biomechanical data that suggests that many of these ways are equivalent. We unfortunately don't have tremendous clinical data to suggest that one technique is better than the other. But I think what you're seeing here and what Tony's demonstrating is that what you have to adhere to is, regardless of the surgical mechanical technique that you're using, you've got to adhere to some of the basic principles of instability repair with capsular plication or shifting the capsule, getting anchors into the right position with the appropriate fixation. So I think if you do that, regardless of the technique that you use, the likelihood of success is going to be fairly high. So our next anchor now, where this is nice and solid, you can see, just to give you a perspective,
You can see we're not quite at the 6 o'clock position, but very close, but we're just inside the posterior band of the inferior glenohumeral ligament. So where his labrum was normal down there, I feel this is very good. In some of the cases you'll see today with multi-directional instability or with posterior instability with significant laxity, as we may see in a gymnast or some of our other athletes, we will come even further anterior, and sometimes we even come all the way up to the anterior band of the inferior glenohumeral ligament to resolve that capsular laxity. The concern with a swimmer would be we would really tighten up that capsule to the point that it's going to be hard for them to swim again. So we're just going to take care of his direction of instability. There's a slight risk in a 15-year-old that there will be an increased chance of recurrence because we didn't go all the way inferiorly, but that seems to be pretty rare when we actually see a true labral tear. When it's a labral fraying or capsular stretching, then we oftentimes have to extend our repair a little bit more inferiorly. So we'll take our suture passing device again, and this one we're going to do it a little bit differently. Notice I haven't put my anchor in, and I'm going to aim towards this direction as you see here. So we're going to just do a twisting with our wrist, so we'll pop down through the capsule again, always trying to not only just move in a direction onto the glenoid rim, but also in an upward direction or superior direction to make sure that we get that taken care of. And we'll slide this on through here and pass this like this, and then we'll grab the suture. And with the device we're going to use now, we actually use a small labral tape. Some of its potential attributes is it's very strong. It also lies down very flat, and as you'll see, it doesn't need a knot with the way that we're going to fix this, so it can be very smooth, which may then prevent some of the rubbing on the articular cartilage. I think this is really valuable above the 3 o'clock position in our overhead athletes. They have a tendency to keep bumping their humeral head. Hold the scope for me. So one of the things, you get a little resistance, so we have to move our cannula so that that suture is coming right through the center, and then that will pop through pretty readily like that. If you keep pulling on it, it's going to catch on the edge of that cannula, and it won't come all the way through. So our tape comes through, and we'll take that suture retrieving device again, and then we'll take our actual anchor, and before we even get ready to put our anchor in place, we're going to go ahead and load that up. So we'll pull this one here. We'll come to the outside of the shoulder where we can keep these at a relatively equal length, and then we'll slide these on our inserter. So these inserters are very helpful because they have these little metal loops, and once they get through, we have to pull this in a way so it pulls directly in line with the hole of that eyelet, or you'll break that eyelet. So we just pull in line with that, and then we'll put a hemostat on this, and it's all ready to go. I personally like to do this before I do anything with my actual fixation so that we're all set and ready to go. Then we'll take the targeting device and we'll line this up, and we make sure that we've expressed our hope that this is the correct size targeting device, so we're all set and ready to go. And we're going to go slightly above where we put that anchor and suture in. And so we'll hold that right in place there, and then we're going to drill right on the rim. And then what we'll do is we'll take our drill and we'll line this up again.
I think this is one of the nice advantages of the knotless construct is once you've got your suture in, you can then select the point of fixation so you can really achieve that north-south shift that Tony's been describing.
Well, one of the things I really like about that, Nick, is that with that very first stitch that we put in, we basically set our tension, and now we're basically just doing a little bit as we keep going up the shoulder, and we don't have to do as much of a big push or anything like that. And so that really is nice to have those sutures on early. We'll load this up. We have to keep an eye on where we put that actually in place. This device, actually, you put the eyelet in place and you push it until the anchor engages, right like that. And then we disconnect the inserting protector, and then we just tap it gently, and if it's in line, everything lines up well, it comes together very nicely for us like that. And then this unscrews from the inserter device that the suture, that the tape went through at the very beginning, that eyelet you saw, that stays inside the bone with the anchor. And then we have a suture, this tape on the outside, and we're going to load this up again. Again, there's a cutting device that goes through a small cannula, so it's a little tricky to thread just by itself, so we have a little tool that helps with that. And again, each company and each device has a variety of different options available. You just have to know what you can do. So then we'll slide on down, load this up, make sure it's in the middle, and cut that. We're going to do one more of those sutures. So at this time, I'm going to change to a crescent-shaped spectrum so that we can gather that all up. So we'll take the crescent-shaped spectrum. We'll come through that same cannula again. We'll go through our capsule. And then I'm aiming upwards, as you see here. We'll capture our labrum. And then we can see exactly where we want to put this. Now, from this angle, sometimes what we need to do is we need to change and actually put this anchor in through the other cannula. I think we'll be okay with what we have set up here, but we can check that. That's the nice thing about having two cannulas available. So again, I've passed this PDS suture. We're going to make a loop in it. There are wire passing devices that are available from other companies, and this company too. So you have a variety of choices. Hold the scope for me. I'll line up the cannula so it goes directly towards that suture, and that way it comes through the soft tissue without being hung up. I'm just going to check real quick. Let me have the targeting device real quick. I'm just going to make sure that I can get the right angle, because if not, I'll actually put it through the other cannula. So if I want to put this up here, we'll back out a little bit just to get a perspective. And I think that looks fine. So we'll be able to do it through this angle right here. So we'll go ahead and pull our other suture with our suture retriever. We go through here, and we have to just keep an... Go ahead.
I said, I think that's a key point, Tony. When you're using these knotless devices, you have to make sure that the drilling portal and the working portal are the same. And oftentimes, as we get down low, we like to place anchors percutaneously. So that is one of the limitations of these knotless devices.
Oh. Absolutely. And it's really important with these. They're more finicky. They're very nice, but they're more finicky. So if you're not right in line with the way you're going to drill and the way you're going to insert it, you're going to end up cracking it or bending it or having more problems with it, and you'll say, oh, this is such a pain in the butt, I don't want to use this device. But really it just requires an adjustment in your technique over what you might have used if you were using a suture only device. So you just have to know your tools and your equipment that's in your toolbox to be able to accomplish the things that you want to do, and then it'll work out just fine. So hand me the drill in my hand here so that I don't have to look away from the screen, and then we'll pass this down through here. So as you see, it's very important also that your assistants know what's going on so that you can keep your eye on the ball as long as possible. You want to keep looking at the screen, have things put in your hands, keep everything in place. I've seen some pretty damaging efforts where the inserting device slides across the articular cartilage, or the drill slides across the articular cartilage in some live surgeries and people I visited, and that's enough to keep you warned that you need to really keep your eye on the ball at all times to make sure that you don't make those kind of errors, which can happen sometimes. So then, again, we've inserted this in place here. If I can't see this very well, one of the things I can do, if you see the arrow is pointing towards the bottom of the shoulder. What I can do is I can turn this around. Try not to get you seasick there, but we'll turn that around and look there, and then we can see it directly straight on a little bit better. Again, with this device, we push until it engages. Like you see there, we take off the protecting hood for the inserter, and then we tap that into position. And that should be nice and secure. Unscrew it, and then we'll take our tapes again. We'll load those through a special tape cutter. That's a very small mouth tape cutter, so that cuts it nice and sharp. And then we slide that on down. I like to cut it flush with the articular surface and not leave tail, so we come right down to here and go like that. So let's take a look at what we have. So the superior labrum is up here, looks pretty good. That's the biceps that's starting to come into view. We start to engage where our posterior labrum was injured here, and then we've got that secured around the bottom, and then the rest of the labrum looks good on the back side. So I'm going to be pretty happy with that in terms of solving his problem, and we'll back out this cannula here. Now, some people would close this cannula. I don't routinely, unless there's a large split in the capsule, which can happen in some patients. But I think the small hole here will heal up. But sometimes the tissue is so flimsy, you put that cannula in there and it'll be about a 2 centimeter rent. And then I think it's worthwhile to put some sutures like a PDS suture and to hold that together. There's really no consequence for this cannula that's over here that I backed out. and then the rest of the shoulder looks fine. Just so you understand what it looks like from the front of the shoulder, we'll back out a little bit. Here's that 3 o'clock position. There's our anterior labrum. There's the anterior band of the inferior glenohumeral ligament. The middle glenohumeral ligament's underneath me. We'll come around the top. There's the superior labrum. The biceps tendon is what's coming out off to the side here. That's your biceps tendon. And then as we come around backside where that posterior labral injury's at, we've got that nice and secure from what we saw at the very beginning on that edge there. You can see that there's a little bit of a flap of tissue. We all like these to look absolutely perfect every single time. And that's what we aim for. That's what we try to do. There's this little flap here. There's really nothing to do for this. You can, if you want, take a little shaver sideways and kind of clean that up a little bit if you like to sweep along with that. But there's really no value in doing that. The security is in getting that nice bumper effect and the tissue all back in the right spot. So Nick, we're at 750, 751. I think we're done here. We're going to close the portals. We're going to put this young man in a sling with a pillow that has a triangle to it. So we call that a neutral rotation wedge, where his left hand is essentially in the handshake position to take the tension off the posterior aspect of the shoulder. And that's what he'll go home with today with his parents. And then we'll slowly go through that thing. So this is what we're going to do. So hold on to the scope for me.
Tony, in just about 30 seconds, can you just comment on your post-op rehab protocol?
Sure, be happy to. So the posterior stability will be fine, this young man, and it will take his shoulder out and just check it, but he'll have no remaining translation posteriorly, just being sure that we have this all well fixed. He goes into a sling, which has a triangular pillow, and that pillow will hold his hand out here in a neutral position. It's actually, with respect to the scapula, it's slightly externally rotated. But in this position, it takes all the tension off the back of the shoulder, and it's a nice way to protect the kids. In our flexible kids, we generally leave that in place for 3 weeks before we even start therapy. And our kids, like our football players or our strength athletes that are doing something like this and get a labral tear, we may put them in this wedge, but we'll start the therapy in 7 to 10 days after they've had a chance to calm down from the surgery. I take the sling off, sling and the immobilizer off at 4 weeks. And we start range of motion. We do not go for maximum forward elevation or internal rotation on posterior instability patients till after 6 weeks, because we don't want to stretch out that capsule. And then from 6 to 12 weeks, we'll progress the range of motion, but we've also now instituted our rotator cuff and scapular strengthening. In fact, you can start scapular exercises, as you know, very early with some shrugs, some pulling the shoulder blades together, and some other activities, which is perfectly fine, but we'll be much more aggressive at 6 weeks. And then at 12 weeks, we can be very aggressive with our strengthening program. We start return to sport type activities. If it's a swimmer or an overhead athlete, typically that return back to that sport for the initiation of return back to sport begins at 4 months. So from 3 to 4 months, we're doing physical therapy, sports-related type activities. But then at 4 months, we actually start this sport again, gently and smoothly. And then by 6 months, we try to get them back full go at that time. Many of these kids do really well by 6 months, but if you carefully look at their outcomes, you will see that they are not back to the same level until 9 to 12 months following their surgery. And that's important to share that with their family. So again, thank you so much for coming and supporting this meeting. I think we have a great faculty. We have a lot of great presentations that you're going to hear today. And I think you're going to take home a lot of important messages to bring back to the patients and the people that you treat on a regular basis. So thank you, and I look forward to meeting all of you.
Thanks, Tony.
Thanks, Nick.